Dear students, in this video, I'll be dealing with depolarizing neuromuscular blockers. So in the last video, we discussed about the non-depolarizing blockers. So your specific learning objectives are the mechanism of action of depolarizing neuromuscular blocker, pharmacological actions of succinylcholine, therapeutic uses and adverse effects of succinylcholine, comparison between the competitive and non-competitive neuromuscular blockers, assessment of neuromuscular transmission, the train of 4. Why train of 4? That is to assess the neuromuscular blockade. Then reversal of non-depolarizing neuromuscular blockade. So these are your specific learning objectives. So about the classification, I have just mentioned about the competitive. I've explained in the last video. Okay, then in this video we have the non-competitive depolarizing blockers. Then the other classes are the where the drug Divya will be dealing with the directly acting muscle relaxants and the centrally acting muscle relaxants. So about the depolarizing non-competitive blocker, only one agent is there which is clinically been used, that is succinylcholine. So succinylcholine, the structure I told, it is similar to that of the acetylcholine. It's like two molecules of acetylcholine bind, it is like that, but it is longer acting. Succinylcholine will get metabolized very fast. Okay, it will get hydrolyzed by the cholinesterase enzyme, but here this succinylcholine doesn't degrade very fast, so it is longer acting. So it undergoes two phases, that is how it acts: phase 1 blockade and phase 2 blockade. In phase 1 blockade, membrane is depolarized by opening the nicotinic or acetylcholine receptor, and the sodium channels will open, which can cause a brief period of muscle fasciculation. So there will be initial depolarization followed by the muscle fasciculation. In the phase 2, succinylcholine is not metabolized. I told you it is long acting, so it won't get metabolized easily. So it is long acting. So it continues to occupy this nicotinic NM receptors, and it desensitizes the receptors which in the end plate, muscle end plate. Okay, in phase 1 blockade, it acts within a rapid, very fast. It acts, it causes depolarization. Whereas in phase 2, it is very slow onset. So this is the difference. The difference in action of the acetylcholine and succinylcholine. Okay, acetylcholine, there will be causes rapid cleavage by the acetylcholinesterase. There will be repolarization of the end plate, and what happens, there will be new action potential and contraction can be elicited in case of acetylcholine. But in case of succinylcholine, when there is contraction, succinylcholine muscle contraction, succinylcholine is given, it go and binds to the nicotinic receptors. It won't get degraded fast. Okay, it is degraded by the butyrylcholinesterase. So it doesn't get degrade fast. It is long acting. There will be persistent depolarization of the end plate because it binds very tightly to the nicotinic receptors. Okay, and which finally lead to the desensitization of the receptors, and there won't be generation of the new action potential, and contraction cannot be elicited. So persistent depolarization followed by the fasciculations and the paralysis. So about the pharmacological actions, mainly the small rapidly moving muscles, as I told with the non-depolarizing blockers, isn't it? Just like that, they relax before, small muscles are relaxed first before those of the limbs and the trunks, and ultimately the intercostal muscles, and finally the diaphragm paralysis, and which can lead to the respiratory paralysis. Recovery occurs in the reverse order, as same with the both competitive and non-competitive. The order of the muscle paralysis and the recovery also in the same way. And the muscle relaxation onset is within 1 minute, and the peak effect is seen by 2 minutes, and the duration is about 5 minutes, and longer duration and the relaxation that can be seen even with the continued IV infusion. And as I told you, there is phase 1 blockade and phase 2 blockade, isn't it? Phase 2 blockade is seen when there is a prolonged IV infusion of the succinylcholine, or if the patient is deficient in the butyrylcholinesterase, or there is pseudocholinesterase in the body, so that will be prolonged, that phase 2 blockade is seen. Okay. What are the precautions to be taken in heart failure patients who are taking digoxin, or the patients who are taking potassium sparing diuretic? Why? Because the succinyl choline releases potassium into the blood. So there will be hyperkalemia. So it is not, it can lead to arrhythmia in such patients. In patients with burns, extensive trauma to the soft tissues, in all those cases there will be it is risky. And patients with rhabdomyolysis, subspinal cord injury with paraplegia or quadriplegia, children below 8 years of age, it is contraindicated because of the rhabdomyolysis develops. What are the therapeutic uses? It is suitable for the short-term procedures, just like as I mentioned in the competitive blockers. Rapid endotracheal intubation during the induction of the anesthesia as an for the intubation procedures, okay, for the short-lasting procedures it is. So you can give succinyl choline. Adjunct to anesthesia, especially in case of the abdominal surgery, orthopedic manipulations, wherein there is any dislocation, okay, dislocation of the joints, or if they have to do some short procedures they have to do for the fracture setting, then laryngoscopy, bronchoscopy, esophagoscopy, in all those short procedures as an adjunct to the anesthetic it can be given. In electroconvulsive therapy, okay, it is given with mivacurium or along with the diazepam. Why? To protect the patient from injury during the ECT, cerebral anoxia and trauma. So another use in the spastic disorders like tetanus. So these are the therapeutic uses of succinyl choline. Now what are the adverse effects? Most common adverse effects seen with the succinyl choline is the muscle soreness. So, okay, and there will be transient intraocular tension also, that has also been found with this. Then hyperkalemia, as I mentioned you, the hyperkalemia that is there. So that's the reason it should not be given along with the patients who are having heart failure, who are taking digoxin and all. So that is because of the release of potassium in the blood during the fasciculations. Increased intragastric pressure that has been found. Another thing is succinyl choline apnea. Apnea is seen in the patients who are having the pseudocholinesterase, or the patients who are having deficient in butyrylcholinesterase, they develop succinyl choline apnea. Malignant hyperthermia. Malignant hyperthermia is seen especially when this succinyl choline is given along with the fluorinated general anesthetics like halothane. Along with halothane, if you give, the patient will develop malignant hyperthermia. So how do you manage that? You have to give IV dantrolene. IV dantrolene is a drug of choice which is a directly acting muscle relaxant also. Okay, so rapid cooling of the patient and IV dantrolene. And another risk is cardiac arrhythmia. Why cardiac arrhythmia? It's because of the hyperkalemia, and this cardiac arrhythmia can even lead to the cardiac arrest also. So that should be taken care. Patient has to be monitored if you are giving it for IV infusion for a long term, in the sense if it is a long lasting procedure. So how do you manage succinyl choline apnea? So as I told, succinyl choline is hydrolyzed by butyrylcholinesterase. So due to atypical pseudocholinesterase, or if there is any deficiency of the butyrylcholinesterase in the body, the patient won't able to hydrolyze or the metabolize the succinyl choline. So that's the reason for the succinyl choline apnea. So how do you find out the presence of butyrylcholinesterase in the body? That is by seeing the Diebuchen number. You can see whether the patient is deficient of this butyrylcholinesterase or not. And how do you manage? There is no specific antidote available. You have to give the artificial respiration. Respiratory support has to be given to the patient, and fresh frozen plasma should be infused. Why? Because fresh frozen plasma contains the butyrylcholinesterase, or which can metabolize the succinyl choline, and patient should be ventilated artificially until full recovery. So that's how to manage the succinyl choline apnea. Now about the neuromuscular transmission assessment. So that why you have to do, so or how you will do. We'll see how it will be done. It will be done single twitch stimulation, train of force stimulation, technique stimulation, and two other modalities are also available, that is double burst stimulation and post technique count. Most commonly which has been practiced is the train of force stimulation. So what is train of force? It is nothing to assess this is the method to assess the neuromuscular blockade. Okay, so in this procedure, 4 electrical stimuli are delivered to the motor nerve at high frequency, that is typically around 2 hertz over a short period, usually for about 2 seconds. Okay, and how it is calculated that so from the 4 twitches, 4 muscle twitches will be the, that is T1, T2, T3, T4. Okay, so that will be compared, that is the 4th muscle twitch will be compared with the first muscle twitch. Okay, and the ratio will be taken. So if there is a decrease in that T4 by T1 ratio, if it is, there is a decrease, it indicates a greater neuromuscular blockade. Okay, so if it is below 0.7, what it indicates? Significant neuromuscular blockade. Or if it is above 0.7, that means that there is adequate muscle recovery and minimal neuromuscular blockade. So that is a train of 4. So this is how it is, 4 muscle twitches. Okay, gradually when you increase in the dose of this non-depolarizing blockers, that is the competitive blockers, the twitch will decrease and finally there won't be any muscle twitch. Okay, that's how it is. So that means there is complete blockade. Okay, here you will be comparing the first with the fourth and you will take the ratio. So that's how it has been done, train of 4. So why to monitor the neuromuscular transmission or the junction? Because variable individual response to the muscle relaxants and has got a narrow therapeutic window and no detectable block when this, so it actually about the receptor occupancy by this neuromuscular blockers, that is 65 to 75% of the receptors are occupied, no detectable block. Paralysis is complete at 90 to 95% receptor occupancy, and adequate muscle relaxation corresponds to the 85 to 90 receptor occupancy. It is like that. So how do you reverse that? The muscle blockade, neuromuscular blockade, how do you reverse? And note down, this reversal is possible only with the non-depolarizing neuromuscular blockade. Okay, not with the depolarizing one, that is with the succinylcholine, reversal is not possible. Okay, because there is persistent depolarization and desensitization of the receptors is happening with the succinylcholine. Okay, that's the reason it is not possible. So how do you reverse here? That is by giving the anticholinesterases like neostigmine or pyridostigmine can be given. So how they are helpful? What is the rationale for giving neostigmine or pyridostigmine? We call it as decurarization also. Okay, reversal we call it as decurarization. So here how they act by inhibiting the cholinesterase enzyme. So it prevents the breakdown of acetylcholine in the body. So what happens? Acetylcholine level in the body will increase. So I told you it's a competitive blockade. If you increase the concentration of acetylcholine in the synaptic cleft, it is reversible. You can reverse the neuromuscular blockade. So that's the reason we are giving neostigmine or pyridostigmine. Okay, it can also increase the release of acetylcholine from the motor nerve terminal. So if there is any unsuspected residual block, okay, patient may start with hypoventilation, that will be leading to hypoxia and even apnea. So especially if the patient has received central depressant medication. Okay, so reversal, you have to give neostigmine or pyridostigmine, but giving prior to this neostigmine or pyridostigmine, you have to give atropine or glycopyrrolate. Why? Because I told no, it can causes bronchospasm because of the release of the histamine. To relieve that, you have to give the atropine, and even hypotension also it causes, isn't it? Because of the histamine release. So to counteract that hypotension and bronchospasm, you have to give atropine or glycopyrrolate, which are anticholinergic drugs. And another drug what you have to give is the antihistaminics. Why antihistaminics? Because you know with the non-depolarizing neuromuscular blockers there will be release of histamine. So in order to avoid the reactions or the adverse effects caused by histamine, you can give antihistaminics also. So that's how you reverse the non-depolarizing neuromuscular blockade. Another agent which has been used for the reversal is Sugamadex. That is a selective, and that's only one agent which is a selective relaxant binding agent, SRBA, selective relaxant binding agent, only one agent available which causes the rapid reversal of the effect of the rocuronium and vicuronium. How? By decreasing the plasma concentration of these drugs. So this rocuronium, when it is freely available, increased concentration when it is available in the plasma, Sugamadex when it is given, it forms a complex. Okay, it forms a complex which gets typically excreted from the urine within 24 hours. So that's how it acts. What are the adverse effects seen with the Sugamadex is hypersensitivity reactions like pruritus, urticaria, such hypersensitivity reactions has been reported. Then marked bradycardia will be there. It may progress to the cardiac arrest, coagulopathy and anaphylaxis. Very rarely 0.3% cases has been reported with the Sugamadex. So these are the adverse effects with the Sugamadex. Now the comparison, how do you compare and contrast between the competitive and non-competitive blockers? Okay, so here that is one is non-depolarizing blocker, the other one is a depolarizing blocker. The antagonism or the blockade is competitive, where here it is non-competitive. there is persistent depolarization will be the. Here it is only single block. Here there is phase 1 and phase 2 block, and you can reverse the blockade by anticholinesterase by giving the neostigmine or pyridostigmine, but here you can't reverse the effect. Then initial fasciculations are not present with the competitive blockers, but it is present with the succinylcholine, and this has got a slow onset and long duration, but this has got a rapid onset and short duration. And it has got certain limitations as I told with the older agent, not with the newer one. Newer one it is less. Okay, so releases histamine, but here it doesn't release the histamine. So these are the differences between competitive and non-competitive depolarizing blocking agents. So that's about the depolarizing blocking agent succinylcholine. Thank you students. Happy learning.